everybody. Thank you so much for joining me. My name is David Binder. I'm the Director of Innovation at Spaulding Rehab Hospital, and this is the Spaulding Innovation Lecture Series. And today, we are welcomed by Esteban Gershanik from Brigham and Women's Hospital. He's a physician in internal medicine and pediatrics, but has a very unique background also in health system management, public health, as well as informatics. Esteban, thank you so much for joining us.
Thank you, Dave. Happy to be here.
All right. Well, thank you for taking the time out of your busy schedule and talking to us today about innovation and technology and things like health equity and health disparities. I always like to start things off a little bit, just talking a little bit about the speaker and their background and kind of what led them to where they are now. I think that's always kind of an interesting topic. Career paths can be very different from person to person, and I think it's always something very interesting. So I was just wondering if maybe you could take a few minutes to tell us a little bit about kind of what brought you to where you are now. You're originally from Louisiana?
Yeah, I often say I'm your typical American Argentine Jewish kid who was born in Shreveport, Louisiana, moved to New Orleans at 4 years old, and grew up there. Who ended up going to college at Emory University, where I also ended up minoring in African American studies while also being pre-med and briefly in the business school, and then ultimately took a career path in both medicine, public health, and informatics. So, typical story. But professionally, for me, growing up, I always was sort of my dad was a doctor, but I was always the person there helping people out. So when I decided to go to medical school, it was one of those things where I said it wasn't going to be the only thing I was going to do, and I always tried to solve problems. And so I went to medical school with a dual degree for a medical degree and a master's of public health and health systems management, and eventually did a residency in internal medicine and pediatrics because I was interested in sort of solving all people and the system itself. And so I thought it brought a broad perspective. And subsequently, just starting my second year of residency was when Hurricane Katrina hit in New Orleans and throughout Louisiana. And I found myself by default and by accident being in charge of allocating, credentialing every doctor with every first responder, wildlife and fishery, military, EMS, and sort of putting those pieces together. So for me, it sort of highlighted what can happen during a disaster and also showed me the importance of technology. I always got frustrated. I enjoy being at the patient's bedside and talking to them and making the situation as easy as possible for patients and providers. And I found during Katrina and even during residency, I was looking through information more and more, and I didn't understand how my phone was so easy to use, but the system was so complex. So ultimately, I did this informatics fellowship in Boston, which was between Harvard and MIT, in order to learn sort of how can technology improve the healthcare delivery system as a whole.
So I totally agree, Esteban. That's a really good point, and I know that you've done a lot of different things and a lot of different projects, and it's really impressive. And I know you've had a lot of fascinating collaborations. What are some of the folks that you feel are also kind of in this world and kind of working on some of these problems that we've been talking about?
Yeah, at Brigham and Women's Hospital, we have folks like Cheryl Clark, who does a lot of work around health equity. She's a physician in my hospitalist group. And recently, this last year, her and Jorge Rodriguez and David Bates had an article in JAMA earlier in the summer, late spring, called Digital Health Equity as a Necessity in the 21st Century Lives Act Era. So something I would recommend people to take a look at because it hallmarks some of these issues that are complex with both health equity, health disparities, and technology issues. So I'd recommend people to take a look at it, along with work that's been done around the digital divide by Lenny Lopez and other folks in the field.
Well, like you said, it takes a team, takes a village, and so we all got to work together.
Indeed, some great people doing some great work out there.
It got me thinking. It's with what we've just gone through, COVID, or we're going through with COVID, and some of the challenges that we've had and had to address with things like credentialing. and getting providers into the state, going through that whole process with the technology that we had now. Katrina was 15 years ago, about?
Yeah, exactly. 15 years ago.
Yeah, and so I'm just, I know that you were really kind of in the thick of things there. I can't imagine having to deal with some of the issues that you were dealing with without, with 15 technology from 15 years ago. How did you kind of go about that? How did you organize yourself, and what kind of infrastructure did you have at that time?
Yeah, no, it's interesting. So, New Orleans itself is a city that is underwater. Literally, it's below sea level. And all the hospitals at that time, most of them had their generators in the basement. So when all of them got flooded, they didn't have their generators to back them up. And during that time, what I ended up doing was literally creating a basic Excel spreadsheet of all the providers we had, all the nurses, all the EMS, all the requests and where resources were needed. So basically just organizing things in a fashion in order to sort of make sure we had all our resources allocated in the most appropriate way. And so at that time, then there was also a lot of paperwork that we did. But what was interesting is you saw a week after Katrina, 1 to 2 weeks after Katrina, a lot of the pharmacy industry and insurance industry collect all the data on patients to know what their medications were. And so it was interesting in 2005 having at your disposal, if you're able to access this link, mainly knowing what patients had from a prescription standpoint. So, a lot of these people were leaving their homes, didn't have their medications. They were dispersed throughout the country. And so you could access this website to understand what medications they were on, which is something, ironically enough, during that time, one of my attendings at that time who I got involved was Karen DeSalvo, who ultimately served as the head of the ONC, which were the folks that, pushed the HITECH Act for the implementation of electronic health records and the push for interoperability. So it's interesting how lessons learned from Katrina have translated to some of the work around adoption of electronic health records to the current issues that we find today, where some of the infrastructure issues that have historically been around are slowly changing, and that there also needs to be a merging of all this information in the same manner, because we're still struggling, I feel like, in our healthcare delivery system to have all that information in the same spot to provide the best care for our patients.
Right. And I know that from Louisiana, you came to Boston as a physician, but also had some roles here in Boston, and then you recently went back to Louisiana for a pretty prominent role there as a chief information officer.
Yeah, no, it was, the great thing about Boston is it's a hub for all the resources, right? So, I mean, where else can you have some of the top hospitals in the world, top institutions in the world like Harvard and MIT, and be able to be in this world of innovation and technology and healthcare delivery? There's no better spot. And so I went from an area that didn't have resources to one that did. I stuck around Boston for a little bit, where I was clinically seeing patients as a med-peds hospitalist between Brigham Women's Hospital, Boston Children's, and Dana-Farber Cancer Institute. And then I was also taking administrative roles here as a medical director for our hospital medicine units, working for Partners eCare, implementing electronic health records, and then doing some innovation and research work around applications. And then this opportunity came around to sort of go back home to help out in the setting of Medicaid expansion, the opioid epidemic, and serving as both their chief information officer, their health informatics director, their emergency response consultant in part of the region, and also working as sort of one of the quality positions for Medicaid expansion and Medicaid when it was going through that now 4 years ago.
Just a couple roles, just a little bit of responsibility, right? It must have been very satisfying to go back home and continue contributing to your community. And I know that health equity and addressing health disparities is something that you feel very passionate about. I'm curious, those terms are used a lot. Can you tell us what they mean exactly? When people talk about health equity, what does that mean exactly?
Yeah, I mean, it's so let's take a step back a little bit. So health disparities as a whole is the idea that can be really sort of, it's like those preventable differences with the burden of disease, injury, violence, and breaking it down by sort of sex, race, ethnicity, income, education, all the sort of various factors that contribute to these disparities of care that we have around different populations. And the idea of equity, one of the great pictures I think that's always provided when you look at health equity is either the ladder or the bike to make sure that everyone's on the same standing to assist to improve their healthcare delivery. And if you think about the Institute of Medicine, when they sort of push forward for their 6 domains of healthcare quality, mainly people think about the fact that they say safe, effective, patient-centered, timely, and efficient. But the 6 pillars they had was to make sure that care was equitable, to ensure that no matter of any individual's personal status, characteristic of gender, ethnicity, geographic location, socioeconomic status, it should be equitable care for everyone. And so that's something that I think has been ingrained from both the Institute of Medicine over the last couple of decades, but has come to light, I think, in the setting of, what sometimes these disasters show is some Band-Aids that we put on longstanding structural issues that we're trying to address. And interesting enough, even when I went to Louisiana, in government, some of the databases and the structure of things are a little bit harder to change because they don't have the resources as much versus, some of the innovation groups where you have private equity at your disposal. So having worked in both, it's interesting to see because in innovation and sort of the private equity world, it's like, let's do something quick. We got money and do it. And in government, it's like moving slow. So one of the things that we saw, and this is the idea around healthcare disparities and also technology, is some of the databases that we've had for ages are really old. And so in Louisiana, we had the hospital inpatient discharge database that only had for race, Black, white, and other. And so if you really want to connect with patients and you know that you have a large Spanish-speaking Latino population, which we have in New Orleans, along with the Vietnamese population in Louisiana, if you're not capturing that data, how can you then build solutions to understand what the problem is and how to solve it? So there's a long-standing aspect of what health disparities is, what health equity is, and then the role that we have in healthcare delivery and technology to solve those things.
Yeah, no, that's so true. It's almost like you have health disparities and health inequities, but there's also a technology inequity. You could have technology available that could help, but if you don't have the resources to implement that or to incorporate that into your existing systems, not going to be able to do anything with that. So it's kind of a multifaceted problem, and it seems like that's one of the major challenges now. But I'm also curious, what other barriers do you see in terms of trying to address health disparities? And do you think that they're similar across the country, or do you think that certain regions of the country have different issues compared to others?
Yeah, no, that's a great question, because I think there's a variety of aspects of health disparities. And I think sometimes people look at it just through the lens of what their work is. I think one of my colleagues used to say true innovation is looking at a problem through various lenses so you can find a solution to it. And what you see is breaking it down by each component. First, what the infrastructure is. So there's some places, it's interesting, I think it's 21 million people in the United States don't have broadband. So in certain areas, the structural context of a city, for example, in Boston, I think only 81% has broadband in the area of the population, and 15 to 20% in Boston don't have a device, is what I found out. And that's different. We're at a technological hub here in Boston, a really rich city at the head of technology and innovation, and still 15 to 20% of the population not having a device or broadband access. And so that goes to long-term structural issues that we have. In some small pockets, we have all the resources, and others we don't. And then that goes into looking at every aspect of certain counties more than others. So there's socioeconomic, educational components. And then also when you look at city versus rural, there's also some disparities between rural versus urban issues across the United States. And then there's aspects you can even think of of age. Younger kids nowadays are doing everything on their phone and are so easy, but you can have an older generation that don't know or don't have that digital literacy. And then you have language issues. So many of our innovations are around English and not about the variety of populations that we have here. And then we also have folks that have disabilities or ALS, where you have to sort of lean on eye technology and other technologies. So I think, there's various components of it. It's the not having the device. So for us to have this Zoom call, we have our computers or phones. 2, we also have the broadband to connect us. And 3, both of us are familiar with the technology. So we have that digital literacy as well. And then you can think also for your older geriatric population, sometimes they have a healthcare proxy or a family member that need to assist with them. So the disparity is so unique with everything from socioeconomic, race, age, disabilities, language. And I think all those things, and urban versus rural, all those things are different across the United States. And are issues I think you need to address when underlying ultimately this multifaceted, multi-tiered issue with health disparities and health equity and technology, or Techquity as we framed it today.
No, that's right, and it's something I've thought about, and I know you have as well. There's the real push to incorporate technology in the delivery of healthcare, in the collection of data, which makes sense, and there's a real value to that. But you're absolutely right. If you're targeting mobile users, that's great. But what if you don't have a mobile phone? And what if you, like you said, what if you don't have broadband or a laptop or a computer at home? So yeah, it seems like there's a broader question here. How can we provide some of these services that aren't actually health-related services? If you think about it, having a mobile phone or having a computer or broadband isn't often thought of as a health-related type of service, but it kind of is becoming related to the delivery of healthcare, and so things like that are becoming a little bit more important. I know that some cities have thought about implementing kind of free internet kind of throughout the city, kind of internet hubs. So it seems like that's going to be part of the solution here, don't you think?
Yeah, and not only that, but just think about what we're going through right now with the COVID-19 pandemic. People are now, there's been a rise of digital virtual care, people doing telehealth and digital care that has increased. There's some numbers that say anywhere from 50 to 175 times. Well, that's for the people who have access to it. So then for those people who didn't have access beforehand and now don't have access to computers, like it's creating a greater digital divide than ever before. And not only that, but there's many people who may just have enough for just one phone. So what happens if they also have 10 kids at home who are also doing virtual school? Like it's almost impossible to take into account those things, or people who are essential personnel. And I think we have to really start thinking about these things, because there's some folks who are essential personnel who are working 7 to 7. So our usual clinic days won't fit them in while they're at work, or they may not have the devices. And so we're even, for some of the work that we're even doing at Brigham Women's Hospital, we're thinking about how do we provide some devices to folks to take them home. So almost like a borrowing. And I think down the road, we may have to start becoming more like a Best Buy that has a geek squad. And instead of having like a community health worker, we're going to need to have like a digital health navigator of some sort to help figure out how we can bring people together greater to connect them, so that we can sort of diminish both that health equity disparity and that technology disparity that we have with some of these populations.
It's an interesting thought. The underlying all of these things that we're talking about is the financial aspect of it. How do you pay for it? How do you show value for it? But it's an interesting thought that the reality of it is that in the world that we live today, the expenditure of something like maybe a mobile phone to provide that for patients may ultimately reduce future health expenditures by just improving access, improving communication between their healthcare providers. And that's a conversation I think that we just weren't really having 10 years ago.
Yeah, and there's some programs, I think it's also getting out of the silos. There's some programs from the governmental and public standpoint where people can get a free smartphone. And so how do we go outside the realms of our traditional healthcare system and figure out how to partner? But then during these times when many people are finding themselves unemployed, do they use the money for, this is when you also have to collect that social determinants of health issues like food versus technology. Well, food is more important. Medications versus a smartphone, housing insecurities. Like, we have to start putting all this picture together and understanding how complex and difficult it is for some of our patients. Because if they don't have a job and they have a smartphone, are they more concerned with also making sure they have the smartphone or they can get food for the entire family? It's one of those things that are a more complex situation than just providing the healthcare that we think, that we went to go study medicine for, but understanding the broader social impacts or socioeconomic impacts that involve the care and the daily life of our patients. And the other thing that we're also doing, we're starting a pilot soon at one of my hospitals where we're actually screening people because, there's some specialties that don't have in-person visits still. They're just doing virtual visits. So we're trying to figure out what specialties are doing virtual visits versus in-person visits. And then what do the patients want? Do they have the smartphone or the access to have a virtual care visit? And if someone lives an hour or 2 hours away, it's much easier for them just to log on for a virtual care visit. So taking all those things into consideration, I think, are key important aspects of how we provide the best care we can for our patient population.
Right. No, very, very true. A lot of things to consider, a lot of things to think about. So it's people like yourself that are going to solve these problems, right? No pressure, right?
It takes a village. Hence why we have people like you as well, Dave.
Well, thank you. I wanted to ask you about one more thing before we close it out, and we're really appreciative of your time. Is you also are very passionate about informatics, and I know that that's something that is very important, but also a term that's used a lot and sometimes not really understood. So I was hoping that you could just tell what is informatics and how is informatics important in kind of what we're talking about here.
Yeah, when I first did an informatics fellowship, people said, "Oh, so you're a computer guy?" I'm like, I have no background in computer. The first class I took was a class at MIT where, after doing a med-peds residency and a public health degree, I found myself with undergrad at MIT, and that was a nice reality check of what I don't know and what I can't learn, and how much space we have in our brains. But informatics is the idea of how technology, processes, and quality can sort of merge with the healthcare delivery system to unite it together so that we can push forward as to the best system that we can provide. So I think sometimes people think of technology, and informatics is the idea of process, operations, technology, and putting all that together. And there's 4 different parts of informatics. There's bioinformatics, which is how we use predictive modeling to figure out the genome and all the genetic stuff like 23andMe and all these other things that we're doing. There is clinical informatics, which is something that I do, which is how do you do the clinical processes and combine the best evidence, the best technology together to provide the best healthcare delivery for patients and providers in the system. There's imaging informatics, which is, with everything from virtual reality to voxels and MRIs and the technology advances that we've had in imaging. And there's population health informatics, which are things like following the spread of COVID-19 and predicting where it's going to go. And so some of the things around that are also health maps that have sort of shown how H1N1 and other epidemics in the past have been monitored and predicted.
That's great. So it's very complicated, but I think that explanation really helps us understand, the importance of informatics, like you said, especially in these times where tracking data, collecting data, organizing data, can be extremely important. So I appreciate your time, Esteban. This has been really informative and really interesting, and a conversation we could probably have for hours and hours. There's a lot of different ways to think about these things, and a lot of different opinions on how we should move forward with some of these aspects, especially when it comes with technology and which technologies are most important, which technologies should be implemented first, and with whom, right? So I really appreciate your expertise and interesting perspective. Any final thoughts on kind of what you see on your end in the future? Kind of what's going to be on the horizon in terms of whether it's technologies or innovation from your point of view?
Yeah, no, I think, we've had a lot of dollars and a lot of apps explode over the last decade, right? And so I think one of the things that we've seen now is that a greater disparity occurring. And so how do we solve these more complex problems? And I think a lot of the excitement around, for example, AI, we now know that some of the algorithms don't take into account certain populations. So I think we're going back to the core of making sure we collect data the right way, build predictive models with an inclusive group of people, and then making sure that we have more people around the table to understand these problems with different perspectives. So I think the more people we have around the table of different backgrounds, the more we can sort of figure out how to solve these solutions, solve these problems, better said, and create better solutions. Because in the past, we haven't had that diverse population around the table. We've had some super smart people innovating some great things. But I think the more we hear from different people of different backgrounds, the more we can sort of ensure that we have that user-centered design and the needs that we need for evolving down the road, and things that are just outside of the healthcare delivery system. So everything encompassing. So it'll be an interesting time in our future. So where I see challenges means that there's also great opportunities. So I think it's an exciting time to be in the field and try to solve these challenging problems.
That's well said, and I think the idea of a user-centered design, I think, is going to be very important. Especially as we develop and implement some of these technologies, to always keep in mind our end user, our customer, our patient, right? Well, thank you so much, Esteban Gershanik from Brigham and Women's Hospital. It's been a pleasure to talk to you today about this. Thank you so much for taking the time to speak with us.
Thank you, Dr. Vinner. It's a privilege and honor. Keep up your great work.